Greetings, everyone. Welcome to the 170th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Lindsay Sicks. Dr. Sicks received her OD from the Illinois College of Optometry in 2010, and then she went ahead and completed the residency in cornea and contact lenses at the Northeastern State University in Oklahoma College of Optometry, where she also specialized to perform anterior segment lasers and minor surgical procedures. Currently, she is an associate professor and also an attending optometrist for the third and the fourth year interns in the Cornea Center of Clinical Excellence at the College of Optometry. She is also involved in teaching didactic lectures to the students in the areas of specialty contact lenses and ophthalmic surgical procedures. She's a fellow of the American Academy of Optometry, fellow of the International Association of Contact Lens Educators, and also fellow of the Scleral Lens Education Society. She also is the chair of the Faculty Students Liaison Committee for the Academy and also serves on their leadership task force. She is a member of the Communications Committee for the Association of Optometric Contact Lens Educators. And today she's going to take us through her journey, I would say, how to go about fitting orthokeratology lenses, basically focusing on what are the common mistakes and how can we avoid them. I would like to change that with your experience, you're going to share with us that how can we avoid these mistakes and be better clinicians. So welcome, ma'am, onto our platform. And, let me just leave the screen time to you.
Great. Thanks so much for the invitation to be here. I really enjoy sharing what I've learned. And so this is everyone's way to kind of learn from my mistakes. And I'm really also excited to see lots of optometry students on the call. So welcome, everybody. And hopefully together we can avoid some of the mistakes that I've made in orthokeratology. Okay, and I have no disclosures relevant to this topic today. So let's start just with a little bit about what is orthokeratology. And if you're familiar with this at all, we know that it's a temporary and reversible refractive change that we gain from the overnight wear of gas permeable contact lenses. And these are reverse geometry lenses that are designed to change the shape of the cornea. And while there are kind of some ancient methods for this that we know existed, for example, way back in kind of the BC era, there were sandbags that people would place on their eyes, and that would change their refraction and allow them to see better. And so that's kind of the whole genesis of this orthokeratology procedure. In its more current form, it started in the 1960s. And so that's been, let's say, about 60 years that we've been kind of familiar with its current state. With the FDA approval of orthokeratology in 2002, we were able to kind of increase or accelerate the availability of Ortho-K to the general population for fitting. And I know that it's kind of gaining traction in other parts of the world as well. This was also kind of in tandem with the development of these hyper decay materials. So these are materials that allow for lots and lots of oxygen transmission so that when our patients are wearing these lenses overnight, that they aren't having any damage to their cornea due to that overnight wear that we might see problems like with other types of lenses, lower decay lenses. So what happens in orthokeratology is actually changes to the corneal epithelial cells themselves. They compress down and we think they kind of migrate, and that causes a change to the epithelial thickness that results in this mid-peripheral thickening. And what we see then is on a corneal topography, there is central flattening. And this kind of whole change in the profile or the shape of the cornea results in lessened amounts of myopia. So it's not unlike the corneal topographic shape that we might see in a patient that has had refractive surgery who is a myope, where it's flat in the center, relatively steeper in the mid-periphery, and we kind of see that almost like a bullseye type appearance. And we'll show some examples of that later in the talk. So if we could launch poll number 1, what would be poll number 2 from your perspective, I suppose?
Right.
So are you currently fitting orthokeratology lenses in your practice?
Yeah, we have kind of a 50-50 results. We have half of them who are currently practicing orthokeratology, and the other half of them are, wanting to start. Couple of them are probably not interested. So I think they should be listening to your talk very, very enthusiastically to develop that interest, right? Okay.
You can just take a little snooze there if you're not really interested. So let's talk about the patients that could potentially benefit from this technology. We talked about its reduction of myopia. And so these are patients that might be kind of just straight spherical myopes, but they can also have some level of astigmatism as well. So those myopic astigmats would also be good candidates. We'll talk a little bit about who's maybe not the best candidate in a couple of slides. Children are also really great targets for orthokeratology, and we know this from some of the research that shows that orthokeratology can help prevent myopic progression in children. And so that in turn gives that child's parents some peace of mind, right? If the child has 2 myopic parents, they're likely to become myopic. And so if we can prevent that myopic progression, that might help the parents lessen their worry about how myopic their child is going to become and what complications of the eye might come along with that. And then from kind of our perspective, students going out into practice and then practitioners kind of out in the field, this can be a real big practice builder for us. I think a lot of my patients, word of mouth is a big thing. I actually had 2 patients a couple Saturdays ago, and I didn't know that they knew each other, but they saw each other in the waiting room, my 2 Ortho-K patients, and so they were chatting. And so it was funny. I think one had told the other, like, hey, we're doing Ortho-K, go see Dr. Sicks. So that was a fun little moment for me. So hopefully build your practice. And then obviously, if these are pediatric patients, these are patients that you can see year after year until they get older. And then maybe they bring their kids to see you, and then you realize you've been in practice for a while. So let's go through, we're going to go kind of one by one through a few mistakes that I've made. And obviously, these are things now that I'm cognizant of and hopefully try to avoid. So we'll start with number 1, and that would be using unreliable baseline data to design and fit your lenses and determine if your patient is a good candidate. So I'll start this part by saying you really don't have to have the fanciest of equipment to gather reliable orthokeratology data. So I think it's very useful to have a corneal topographer. It does not have to be the latest, greatest model. And so when I was putting this talk together, I thought, well, let me just go see how old my oldest topographer is. And it is from 2001. So it is having its 21st birthday this year. And I thought, well, does that really affect the data that I'm collecting? And in some ways it does, and in some ways it doesn't. So again, you don't have to have the, $30,000 topographer, but there are some challenges that come along with a topographer that is over 18 to 20 years old. And so the light board, at least in our model that we have that I've shown here, the Medmont, the light board can start to kind of go bad after 16, 18, 20 years. And so this is kind of an example of what the difference in the light board would look like. And and ours is kind of off to the right there. The light board is getting old. It doesn't give as good of an image, and that can affect the quality of the data that we gather. And so inherently having this older instrument can cause some problems down the line potentially. Now you could use, at least to start, manual keratometry. You could look at HVID with a ruler, and you can just do your old-fashioned refraction and start your patient. But it's helpful to have a topographer of some sort. At least it helps to have it up front, but also in the kind of fitting phases, so that we can determine what's happening with the eye when the eye is closed. And it's harder to do that just through looking at the lens fit. And we'll talk about that as we go through here. So data, what data do we need? We really need some measure of the keratometry. And so this can easily come from a topography, again, or a manual keratometer. But the topographer is going to give us extra information, right? It can give us information about the eccentricity of the eye and the sagittal height of the patient's cornea, which can both be very helpful in determining our starting lens fit. So we can be a little more accurate up front with this extra information. The horizontal visible iris diameter is another piece of data that's really helpful. This is also called HVID, and that's what I'll tend to call it throughout this talk. On our MedMont topographer, this comes out as a diagonal visible iris diameter, or DVID. So you may hear that term discussed. But you can also do the very low-tech version and measure this with a PD ruler, pupillary ruler, and just kind of figure out what the millimeters are of your patient's HVID. And that's really helpful for determining the starting diameter for your patient. If they have a larger HVID, you may need a larger lens overall diameter to get that lens to center better. Obviously, a refraction is very helpful. It helps you determine if your patient is a good candidate, but also whether, what the expectations are, what the expectations are for how fast their myopia is going to be resolved with orthokeratology. So if they're higher myope, it may take a few more weeks to get to their plano state versus if they're a lower myope. And then their pupil size can be very helpful as well. If you have kiddos or patients with large pupils, they may be more likely to have glare, flare, or halo complaints during the treatment process. And so it's helpful to have their pupil size and bright and dim illumination, and that may affect what you determine in terms of your optic zone diameter when you're fitting these lenses. So again, baseline data, you can use a manual keratometer, an auto keratometer. When you're using a topographer, I will say it's really helpful to have recently calibrated your topographer. Another mistake that I've made going years using a topographer that has not been calibrated because I lost the calibration device. So I eventually gave up and bought a new one, and it's been much better since I did that. So calibrate it kind of at the interval that the software is going to ask you to do it, but you can certainly do it more often. And this is going to help give you more repeatable, reliable mapping from your device. It's also important to pay attention to the tear film. When we have patients that have dry eye, this can disrupt the ability of your topographer to measure the cornea. And I think to kind of think through how that works, you're thinking about your topographer is actually measuring the tear film. And the tear film is kind of like a proxy for the cornea. And so if you don't have a nice, clean, even tear film over the front surface of the eye, it's going to disrupt the image that the topographer is able to obtain. And that is going to then in turn affect the data output that it gives you. Other things that can affect the map would be too much tears. I see this a lot if you put a tear in before you take a map. You can get this kind of inferior, excessive amount of tear film. And that can make it look like the eye is steeper than it actually is. It can almost give you like a pseudo keratoconus type appearance. So you need to be careful for that. And then a lot of times I find with our kiddos, eyelashes, they have just such nice long eyelashes, and that gets in the way a lot of times of our maps. So it can be helpful even to use a cotton bud to kind of roll up that eyelid and get a more accurate map so that the lashes aren't in the way and causing a problem. With our HVID, again, I mentioned on the last slide, it helps us determine the appropriate lens diameter. And when we think about lens diameter here, I think it's a little bit larger than what you might initially think. So usually we want our overall diameter to be 90 to 95% of the diameter of our cornea. So if we don't have the appropriate corneal diameter measured up front, we can't have the appropriate overall diameter for our lens, and then it may not center as well when we're doing our dispensing and our fitting visits. For refraction, it can be very helpful, especially with myopia management when you're fitting Ortho-K, to do your refraction with cycloplegic agents, making sure that the patient is not over-minused. And then the accurate baseline data for our refraction actually determines the base curve of our lens. And so if we don't have the appropriate refraction up front, the amount of flattening or the base curve of the lens is going to be incorrect. And so then we won't get the appropriate result. We'll either get under treatment or over treatment. You can kind of discover this on your own. Again, mistakes that I've made. If you dispense your initial lens and you're not getting the over refraction that you would expect, usually that's somewhere between plano and plus 3/4 of a diopter over the top of the lens, that can be a sign that your initial refraction was off. And again, pupil size, this is just something to pay attention to, especially in kiddos with those larger size pupils. I will say, in my experience, kids are pretty unaffected by this. I try not to warn them up front that it's going to happen, because I think they may get it in their head and then come back and complain about it. But they seem to be pretty unaffected by that glare, flare, and halos with their larger pupil size. I will say the opposite happens when I fit optometry students in orthokeratology. They spend a lot of time in dark rooms doing retinoscopy, and they're not as happy with that glare and flare and halos. So if any of you are thinking about doing Ortho-K, you may want to keep that in mind for yourself. Other things that might be helpful, axial length. Obviously, if we're assessing myopia progression, we want to get a baseline axial length, although that doesn't necessarily help us fit the lens. It might be part of our initial workup. A slit lamp exam is very helpful to make sure that we don't have any underlying blepharokeratoconjunctivitis, dry eye disease. We have a good tear film, lid closure, and things like that. And then assessing the tear film again, so that we have a good baseline tear film for that lens to rest on. And then I can't stress enough to do a dilated fundus evaluation. And this kind of goes not only for your baseline workup, but for every year that you see these patients. We had a case in our clinic last year where a patient had come in for an interim Ortho-K visit, and they actually ended up having a retinal hole, and it was, on its way to causing a retinal detachment. And so that just kind of hit me like, hey, just make sure that you are doing these dilated fundus evaluations at an appropriate interval to make sure that your little kiddos that are at risk for these myopic problems with their retina don't have any problems. Okay, so tip number 2 would be how to not choose the wrong candidate. So we'll talk about things to avoid. We talked about myopia and myopic astigmatism as being good options, but we want to avoid patients who have a high kind of sill to sphere ratio. And so an example would be someone who's like plano minus 175. So they have a lot more cylinder than they have myopia in the sphere. And these can be just more challenging to fit. It's not to say that you can't, but they may have some issues. And so we may have some issues with lens centration depending on their cornea. We may have some issues with visual outcome. So just keep that in mind. You'd rather have more even sphere to cyl ratio or no cyl at all. If the refraction is too high, this would be a high level of sphere, high level of cyl. I always just keep in the back of my mind, if I think this patient has degenerative myopia or pathological myopia, right? If they're coming in and they're 8 years old and they're already a -11, it's probably not something that I can fix with orthokeratology. Not only are they kind of very high in terms of the sphere and not necessarily a great candidate, but this may also be a more pathologic form of myopia where stopping their progression isn't really going to be right. It's more of a genetic, maybe they have a genetic disorder or something else that's causing their myopia. So we do have some designs that have high minus allowances. So is not to say that you can't fit a patient that's that high of a myope, but do keep in mind if you're fitting for myopia progression that your patient may have pathological myopia and you may not be helping them as much as you hope to. Patients with flat Ks, keratometry values, can be very challenging to fit. The whole idea of this is that we are able to flatten the cornea and get extra flattening so that their Ks go more flat. So if they already are flat or on the flat side to start with, it's hard to get that extra flattening. And this is especially challenging when the cornea does not have a lot of eccentricity to it. So when it's kind of flat overall to begin with, getting that flattening can be a challenge. Patients with ocular surface disease, you want to treat that dry eye ahead of time or just avoid altogether. I'm just thinking like a patient with something like Stevens-Johnson syndrome or Sjogren syndrome might not be a good ortho-K candidate. And then certainly if your patient is unmotivated, they're not a good candidate. If the parent is unmotivated, that's also not a good candidate. You really need a motivated kiddo and a motivated parent to fit Ortho-K for myopia management. And you can always look at the patient and kind of with the parent decide, are they mature enough for this modality? And some of that hinges on the independence of lens handling. So you don't want the parent to feel like it's a chore that they're putting the lenses on and off every night. Although in younger patients, you may start there. And eventually, as your patient gets older, they may be able to be more independent in their lens handling. You want to be more cautious in patients that have lid surgery. I say this cautiously. I do have at least one patient that has a history of ptosis repair as a child, and she successfully wears Ortho-K. So we're just very careful about making sure that the lid can still close all night and that she doesn't have any corneal compromise from that. So a relative contraindication, I would say, or just be cautious with that. Again, questionable motivation. Those patients may drop out and then you've kind of done all that work for nothing to fit them and get them going. If a patient has lens handling challenges, any specialty lens may not be the option for them. And then patients that have demanding visual needs or unrealistic expectations probably aren't the best candidates. I like to say with my Ortho-K patients, I love it when they're 20 happy, right? Because they could be a squishy 2025 or 2020 and they're happy as a clam that they don't have to wear lenses during the day. So on our topography, what are we looking for a good candidate? Well, we want a map that's well-centered, doesn't have any data gaps from those lids or lashes that gets in the way. It's also very helpful to us in terms of fitting and results if the corneal apex is near that geometric center of the cornea. When those two things are not together, it creates problems in terms of lens centration. And then we want vertical and horizontal symmetry, an average radius in that 40 to 45 range. Again, we don't want to go too flat on our keratometry. That can be really challenging. We want a low amount, ideally, of with the rule astigmatism. When we get into against the rule cylinder, it again can be hard to center those lenses. Again, not to say that you can't fit that way, But the ideal characteristic would be a patient with maybe a diopter with the role of astigmatism. And then an average amount of eccentricity. And average is really large in terms of eccentricity. We say anywhere from 0.25 to 0.8. When you get over that or below that, it can be really challenging to fit. But ideally, you're somewhere in that middle range, 0.3 to 0.5. And even on the kind of higher end of that allows for easier flattening. So that can be helpful. Mistake number 3 would be trying to fit a spherical lens when you really need a toric ortho-K design. And we'll talk about some of the indications for that. So the number one thing that I look for when I'm deciding sphere or toric is how much corneal cylinder does this patient have? And again, having a topography map is very helpful. And I look at whether that astigmatism is central, kind of all confined to the center, or limbus to limbus. And I'll show you an example of that. I look at the eccentricity difference between the two meridians. And when that is kind of on the higher side, the difference, that can tell me that the shape is different in one meridian versus the other. And so that can be an indication for a toric design. And then depending on the lens design that you're working with, they can go into the topography file with you, or if you send it to them, and you can drop an 8mm cord and look at the sagittal height difference between the elevation difference at an 8mm cord, and that will kind of tell the difference in sagittal height. And so depending on the lens design, they may have different metrics for how they do that. So I'll just give you kind of my experience with the designs that I work with. So with the CRT dual axis design by Paragon Vision Science and the Euclid Emerald toric design, that difference, if it's more than 25 microns at 8mm, is going to indicate that your patient needs a toric lens design. With the moon lens design, that difference needs to be a little bit more in about 30 microns in order for them to move to a toric lens design. So kind of the bottom line is you really want a normal keratometry value, not a ton of astigmatism on the cornea. You want enough eccentricity to flatten the eye. And if you have that larger elevation difference or larger amounts of corneal cylinder, you want to consider a toric. So here's just where that shows up in the Medmont topographer. You can pull up the axial power map, and it will actually give you the sagittal height differential at 8mm. And so this is a patient where that difference is pretty low. But if we look at another one that has, actually this one happens to have more corneal astigmatism, which probably makes sense then, that their sagittal height difference would be more than that 30 micron cutoff. And so this second patient here is one who we would fit in a toric lens design up front. So how can you determine if you made an error? So here's my example of my error. So this is a patient that I fit with a spherical lens design. I think it's two separate patients actually. But two ways you can kind of tell that toricity is needed, okay? One would be if the lens doesn't center very well. And the other would be over on the right here, you can see this kind of leaking of fluorescein in this oblique meridian here. And so when we have that kind of leaking or lift off, it tells me that the lens is not adequately providing that seal off. And so they may need toric peripheral designs. So here's an example of some of that leakage as well. Kind of down on the lower left, and then again on the upper right of this other eye. So we briefly mentioned central versus limbus to limbus. And so if we have astigmatism that is confined to the central cornea, like on the left here, this actually may be a patient that you fit in a spherical lens because the base curve is going to provide the central flattening and kind of mush down that central astigmatism. And then the spherical part of the periphery can land out on the rest of the cornea and be fine. But in a case where you put that same circle on the other side, you can see that the corneal astigmatism extends beyond that circle. So it's no longer central. It's really that limbus to limbus toricity that can cause the lens to decenter and kind of leak that fluorescein, and that can affect your alignment curves. Mistake number 4, and I had to learn this very painfully and slowly, I think, over the last 12 years or so that I've been fitting Ortho-K, and that is, if you make changes too soon, you just really can end up in a bad spot. So I'll go through the expectations and then we'll launch the next poll question. So on our topography, when we're getting good results, we really want to see a classic bullseye pattern on our topographic map. We want an even flattened treatment zone. We want that nice steepening, relatively steepened in the reverse curve area. And then we want this kind of 360 flattening in the periphery that represents our alignment curve. And so the question would be, where do we go to look for that? So if we could launch the second poll, I want you guys to tell me, where would you look for that? And if you don't know, just guess. There's no right or wrong answer here. Well, there's a right answer, but we'll talk about it. So which map do you think would be most useful to help us look at our topography, whether it's 1 day, 1 week? We have axial map, tangential map, or difference map.
Awesome, great. So I have launched and a couple of them have already started to vote. I'm just gonna leave this on for the next 10 more seconds and share the results. Kind of a tough fight between some of the options here.
Yeah.
Right, but yeah, I'm gonna end this and share. So about 41% of them think tangential, followed by 35 who thinks axial, and the remaining thinks it's the difference map which help us to do that. Right.
So the majority were right. We want to look at our tangential map. So let's see, and I'll show you an example here. You can kind of see why. So this would be an axial map of a patient, and you can see kind of the relative steepening and the central flattening, but it's a lot more pronounced in the tangential map. And the reason for that is just the way a tangential map works. It gives us more exact assessment of what's going on at each part of the cornea. And so it's very useful not only in our irregular corneas, determining the type of cone that we see, but also in our orthokeratology patients, looking at what their visual result is, what their corneal result is, and are those things matching up? Is our reverse curve kind of captured within our pupil and giving us that myopia management that we want? Is the overall flattening kind of central and providing the visual result that we would expect? Other things to look out for where you may be tempted to make a change and you really shouldn't would be bubbles in the reverse curve. With students, I find that this happens all the time. They'll put the lens on and say, oh, Dr. Sicks, there's bubbles in the reverse curve. And that means it's too steep, right? And normally that would be our reaction to a corneal GP that we put on. If it has a bubble, we may think, oh, it's too steep in that area. And the majority of the time, I think it's either a solution issue, which can cause this very pretty looking dimple veiling, like what you see on the right-hand side. Sometimes with our more viscous solutions, I see this. Or you can see kind of that bubble like what you see on the left side. And you want to be on the lookout for how much of that return zone or reverse curve that your bubble takes up, okay? On initial kind of dispense, if it's just a few bubbles here or there, honestly, if you leave the lens on and walk away for 10 minutes and come back, a lot of times those bubbles are gone. And the other thing to think about it again is how much they take up. So if they take up a quarter of the entire kind of the 360, they take up about 90 degrees or less, that's probably okay to dispense and see what happens. If it's taking up, 3/4 of that return zone, that could be a problem. You might not get enough treatment. And so in these cases, I tend to have the patient take the lens off and then we put it back on and see if the problem goes away or not. Because again, sometimes it's just the solution kind of making weird things happen in that return zone or reverse curve. Another thing to be on the lookout for would be foreign body tracking. You may kind of think that this is some sort of dryness, or maybe you think the base curve is too flat and it's causing staining. But if the patient does indeed have this kind of foreign body tracking, like you see here, where you have these kind of lines, usually they're vertical or oblique happening, it could be because something just got under the lens and the patient has blinked and it has caused that. So that might not be a reason to make a change, but do obviously investigate, evert the lid and so forth to make sure that any foreign body that's in the eye has been removed. And another thing to look at would be to make sure the lens, it doesn't have any back surface deposits and isn't causing any problems either. So here's kind of where the rubber meets the road, where I have always had issues. And it's kind of making changes, again, too soon, either too soon in the fitting process, or something that I see only once and isn't repeatable. And then if I had just waited longer, I would have seen that it was just either a blip on the topography or maybe the patient slept funny. So topography changes after one night of wear. So your first night, these can completely vary. You can have a patient that gets treatment for, just a few minutes. Their vision is better after they take the lenses off, and it goes back very quickly. So by the time you get them to the topographer, they may not have as much treatment effect as you would expect. That does not mean you need to make a change. Another scenario would be a patient that is a higher myope, and they come in after one night of wear, and again, you're not kind of getting that full treatment. Well, we don't expect that to happen, right? Your 4-diopter myope may only get maybe a diopter or 2 diopters. We always hope for 3/4 of the way, but they maybe their first night of sleeping with these lenses was just kind of rough, and they're not doing as well on night one as you would, or after night one as you would expect. So my mantra kind of moving forward is always, I never make changes after one night of lens wear. So on that day one visit, I'm never changing anything, unless there is some gross fit problem, or something that's going to harm the patient. But if they are getting some level of central flattening, if their vision is improved somewhat, if their over-refraction is what I expect, and they're not having any adverse events, corneal staining, things like that, then I would let them continue on. So here's just some examples of some of the variability that I've seen after one day of lens wear, one night of lens wear. So again, you can get kind of an incomplete central treatment zone, or something that's kind of oblong or oval. That those aren't problematic. We just keep going, and eventually, hopefully, they turn into better looking treatment. So first-time wearers that experience lenses that are well-centered, but they're not getting ideal treatment. I've chatted with some lens consultants about this, and they really say, wait 2 weeks. If everything's going well, you can certainly see them at a week, but you may not even want to make a change until 2 or 3 weeks. And you can gather data along the way to help ensure that their vision is progressing appropriately, their over-refraction remains correct. And then we can always look at the difference map. So again, at one night or one day, we're not making changes. And even after 1 week, we may not decide to make a change. We may wait until we see that patient 2 to 3 weeks later. And I've been surprised. So again, this is a patient, I saw them at 1 day. Okay, they're moving in the right direction. The lens is centered. I saw them at 1 week, and you can see on the left their topography maps. You know, the reverse curve, not totally all the way formed. The one on the bottom, a little bit oval on the treatment zone. Should I make a change? Should I not? Are they getting enough treatment? And so I decided to just wait and watch. And at 1 month, you'll see over there on the right-hand side, the right eye on the top, the left eye on the bottom, both of them turned out perfect the way that I would have wanted. And I didn't even make a change. So this is a case where, again, had I made a change at 1 week, I may not have gotten this nice 1 month result because I'm making changes preemptively. Whereas if I would just be patient and wait for the treatment to fully kind of form on the cornea, I would actually get there. And I think with some of our designs, it's just that waiting to see if that first lens is going to give us the result that we want, especially if it's pretty well centered. So making changes too soon can actually result in overcorrection because you think you're not getting enough treatment. And so we increase the target. And then you can actually end up overcorrecting the patient. And that can cause other issues, especially like binocular vision issues and things like that. So remember that we expect after 1 night of wear an 75 to 80% reduction in the level of myopia. But that's not always the case. So just because you have a 2 diopter myope doesn't mean you're going to be at -0.5 uncorrected after 1 week of wear. You may still have some residual myopia there. So waiting longer can be the key. We also expect for these patients a reasonably large regression especially during that first day. So they may be seeing very well in your office, but warn them that their vision is going to get worse over the day. In the first week, it won't last all day. And this is just the epithelium returning toward baseline, but we really expect that they'll get their full refractive effect with less regression at about 1 week. And I say this all to tell you to educate your patients about this so that they don't call you in a panic, and that panic kind of make you make a lens change when you know that they're kind of still moving in the right direction and they're on their way. So the other half of this part would be making sure that your changes that you're seeing are repeatable. And so when you see something wrong, whether that's insufficient correction of their refraction, or you see this decentration or incomplete treatment ring on topography, make sure that that's repeatable. So you can have your patient come in 1 day and do their topography and it looks like this. And you think, oh man, that's really, not great. It's oblong. The treatment zone is tiny. I'm not happy about it. And if you go to make changes off that, you might lead yourself astray. And then they come back another day and it may look kind of similar and yet different. This would be a case where I would say, okay, it's pretty repeatable, the problem. But had they come back for their second topography on the right and it looked better, I may think, oh, that patient just slept poorly on that first night. Issue number 5 would be failure on the part of your patient to replace their lenses on a reliable schedule. And usually this is annual for our patients. And so we can help with this up front by educating our patients and setting expectations of how often we want to see them back. From that initial consult, we want to see them for a dispensing visit, and then you may kind of build in their follow-up visits, but making sure that they come back every year for their annual exam. We talked about the importance of that dilation as well. Usually we see our Ortho-K patients who are undergoing myopia management at least every 6 months. And that 6-month visit may just be an axial length measurement and a cornea check and a topography check with their annual exam happening in the other 6 months. And then some of our other patients that have a history of complications or maybe our younger patients, we may follow them more closely every 3 to 4 months. You can use your uncorrected visual acuity, residual refractive error, so your refraction, axial length, and your corneal topography to assess the stability of your patients over time. So the question you might have in your head is, well, what can happen if your patient continues to wear their Ortho-K lenses beyond that 1-year time point? Well, if lenses aren't replaced, remember our orthokeratology lenses are made of material that is of a higher decay or higher oxygen transmissibility. And this lends itself to a more fragile type of modulus. And so these patients' lenses can warp or be damaged over time. And the warpage of these lenses can actually change the patient's refractive error. It can cause residual refractive error, changes to their cornea that they may become used to, but you may not actually want them to occur. And you can sometimes see this on topography with a lens that's sometimes it'll be decentered or cause poor or incomplete treatment. But the lens itself, you can't actually see the warpage sometimes. So the question comes up, what do you do with a patient who comes back 2 years or 3 years later wearing the same lenses that you prescribed 3 years ago? And when I talk to lens consultants, they always recommend just starting with a fresh pair of the same parameter lenses and let the patient wear those and see if they have any issues with that. So it's always a good idea for your patient to have a duplicate pair of lenses. And so with that, I mean, they have their current pair that they're wearing, but they also have a backup pair. And that's kind of twofold. We want them to have not only a spare lens if they lose or break one. If they come to your office and say, I broke one, it might take a week or 2 to get a new lens to the patient. And so in orthokeratology, you can imagine that being without a lens can be pretty devastating to your patient. They can't see very well. So having a backup lens is helpful in that scenario. But also just having a duplicate pair with the same parameters can allow for your patient to replace those lenses when the year is up. And hopefully they're still coming back to see you for exams. Lesson number 6 would be trying to achieve the perfect topography map. We've looked at some of these that are kind of not so pretty, but you may end up in a scenario where you always want to get your patient to that perfect map. And in this case, it's the tangential map on the right here, where I actually saw this patient and I said to them, I really want to put your topography textbook. So that perfect circular ring, nice big treatment zone. The patient was super happy with their result. But that's maybe a unicorn, right? It's not what you're going to see with every patient who's successful in Ortho-K, and nor should that necessarily be our goal. Our goal is not to make pretty pictures. And one of my mentors, Jan Jerkis at Illinois College of Optometry, she always says that to our young faculty, of which I was one once. And so she said, Lindsay, your goal on Ortho-K is not to make pretty pictures with your topography. The goal is to help the patient see. So I always try to remember that when I'm looking at a topography that's maybe not perfect or pretty, but if the patient is happy with their vision, they're seeing 20/20, their over-refraction is what I expect, and their lens is in good shape. I need to remind myself that not every fit that we do needs to be in a lecture or in a textbook. Sometimes the best thing we can do for our patient, the fit alone. So do make sure that your topography scan doing everything that you can to get good scans, and that would involve making sure the eyelids are out of the way, that you have a low viscosity artificial tear instilled if you need to help with that tear film. Take several images and choose the best ones. I think that's helpful also to determine if something is repeatable in the moment. And then if you're getting any ring jam or missing data, don't be afraid to retake that image, because it may give you a better image than what you're working with presently. Mistake number 7 would be using improper solutions. And that's on the patient's part as well, but also on our part, if we're not asking our patient what solutions they're using, it can be hard to uncover problems. And so sometimes the best solutions are preservative-free options that can help a lot of the preservative and sensitivity to solutions out of the fitting equation, so that you're better able to make assessments of the lens fit and determine if the problem is being caused by the fit of the lens versus just the solution. So we tend to recommend hydrogen peroxide-based cleaning systems for our orthokeratology patients. If your patient doesn't have access to that, or if they want something simpler, you could certainly use a multi-purpose type gas permeable solution. But just keep in mind that solution sensitivity and that staining from preservatives may be an issue that you see on follow-up. We also like our patients to use artificial tears to apply the lens. So they put a couple drops in the bowl for comfort purposes prior to lens application. This is ideally also free, kind of a single vial unit dose tear. And then when the patient wakes up in the morning, we love for them to put a preservative-free tear in as well, kind of close that eye and make sure that the lens is centered on the cornea and it's mobile prior to removing it. And we prefer removal with a suction cup in this case. And the goal of that process that we set up for our patients is to really prevent any central staining. We know that central staining is one of the most common adverse events we see with orthokeratology, and we want to make sure that it's not a result of solutions and tears in terms of follow-up. So when I say that, I mean, if there's central staining, we want to be able to kind of distinguish, is it due to solutions and easily fixed, or is it due to the lens fit and also still easily fixed, but do we need to change the base curve or the peripheral curves of that lens to prevent the staining? And so we have our technicians and our students at every visit ask about solutions to ensure that the patient is still using the solution that they started with and that we recommended for them. So to help educate your patient, you can let them know that this is the solution that we recommend for you. And the International Association the American Association of Contact Lens Educators, which is an American group, AOCLE, has a downloadable handout on their website, and you can get it in several different languages. But it kind of guides your patient through their orthokeratology lens care, healthy habits that they should have, and you can write their solution down on that sheet of paper and hand it to them. And with that, it kind of reminds them, hey, if you run out of solution, don't go substituting a whole different brand on your own. Please let us know if you want an alternative option, and we can kind of give the yes or no to that. And most solutions that we would recommend can be found locally for each patient, or some might be lenses they can purchase online and have delivered to them. So here's just a little case of a patient I saw that had central staining. And up front, we asked the solution questions and were able to determine that this was a patient who had successful in Ortho-K for 3 years, had seen us every year, but the couple weeks prior to coming to the office for their annual visit, they had run out of their Boston Simplus that they using to their multi-purpose solution because they were on vacation and they were in Mexico and they couldn't get any more of that. And so they were in a hotel room with their dad and used their BioTrue, which is a soft lens multi-purpose solution. And then on the same trip, he had also run out of preservative-free artificial tears to apply and remove the lens. And so it was pretty easy for us to determine in this case that the central staining was not likely a result of the lens fit, but more a result of the solutions. And we were able to duplicate the lenses, have him change the solutions, and he came back and that central staining had resolved. We're almost in the home stretch here. So mistake number 8 would be thinking all orthokeratology lenses are the same. There are multiple different designs. And we were chatting before we started the talk about kind of the proliferation of those designs in other parts of the world. And so while it is true that all orthokeratology lenses follow the same basic design principles that we started out talking about, they're all reverse geometry. They all aim to reduce myopia. The lenses themselves can differ in how they control their reverse curve. So they may have different curvatures between designs. Some may have computer-generated curvatures. And this can affect not only how quickly your patient gets to their endpoint, but also, the treatment zone size and things like that. They also can differ in how you approach the fitting process. And this has advantages and disadvantages, I think, for each individual practitioner and how they want to approach their practice. And so you can have empirical lens fitting, where you just kind of collect all the data up front, send it to the lab, and they send you a first fit lens design. And you can put that on the patient. And as long as it is well-centered and the patient sees well and your over-refraction is what you expect, you can dispense it to the patient. Another approach would be the inventory fit set. And this would be we call it a suitcase in our clinic because it's a very large set of, up to 1,000 lenses where you have them kind of all sitting there and you gather your patient's data, determine their first lens, go to your fitting set and choose the appropriate one for them and send them home with that. And so I think there are inherent advantages and disadvantages to each of these. And depending on how much space you have in your clinic and how often you fit orthokeratology, one or the other of these may be more sensible for your practice. And there are also designs that have both types of options. And so again, you can decide which is better for you. So in general, in terms of lens design, if we're talking about myopia management, we want to think about maybe smaller treatment zones on the 5 millimeter side versus the 6 millimeter side. There is a lot of research going on in that right now. We want lenses that have a positive asphericity on the posterior curve that can give us a higher kind of reservoir depth that can affect the level of efficacy we get with myopia management. We want the periphery to maybe be a little bit tighter with less tear exchange. And this can ensure that we have a nice mid-peripheral seal-off that helps, again, with our myopia management. It's going to improve, maximize the convex power that we're trying to create in these patients. So the number 9 here would be failing to use a topical anesthetic for your initial kind of dispensing visit. So I kind of pull this concept over from corneal GP or corneal gas permeable rigid lens fitting. I think it's a similar application here with orthokeratology lenses, which again are the same material. Your topical anesthetic is going to provide improved comfort on initial lens application. I also find it's very helpful to get us a good over refraction result. Okay, when we're putting these lenses on our patients for the first time, we really want to know, can they see through them? And what's our over refraction result? Because that's going to help us gauge whether the base curve is appropriate and whether the lens is going to give us a good result at the 1-day visit. In some kids, I find this is also kind of an anxiety mitigating factor. Kids can be pretty nervous. And so if you're going to kind of put them through something that they've never been through, it can be helpful to just kind of say, hey, we're going to put a magical drop in. It's going to help help us get the lenses on. So let's go ahead and do that. And it kind of eases some of their anxiety. There are some disadvantages to the use of topical anesthetics, so you need to be aware of these. It can cause some increased staining because anesthetic by nature softens the epithelium. You could end up inducing an abrasion, a corneal abrasion on your patient. You could also have a problem getting insufficient amount of tears underneath the lens because your patient's not tearing because their cornea is anesthetized. You may have issues. I think that is mitigated by putting in fluorescein because you're adding liquid to the eye. The main argument, I think, against topical anesthetic would be your patient is not going to have the advantage of topical anesthetic when they are at home putting the lenses on that night or whatever their first night is going to be. And so using topical anesthetic in the office does not provide a real life experience for them. And kind of my thought on that is after 10 minutes, the topical anesthetic has really worn off anyway. And so if you keep them on for longer than 10 minutes, that patient is going to start to experience what they're actually going to feel. And if your application and removal training takes any longer than 10 minutes, which it usually does in these cases, they'll get a sense of how it's going to feel when they take the lenses home. All right, our last one here would be making changes based solely on the on-eye fit of your lens. So let's review what we're looking for ideally on eye. We want a lens that is well-centered. It's going to have a fluorescein pattern that looks like what we call a bullseye, where it is flat in the center and has a nice mid-peripheral ring of fluorescein in that reverse curve or return zone. And then in the alignment curve, we're going to have minimal to no fluorescein. And then we get a little bit of fluorescein there at the lens edge. And so I say all this because you want to look at the lens and make sure that it fits well. But there's also something to the fact that the way the lens looks on the eye doesn't necessarily translate to how the outcome is going to be after the patient sleeps in the lens. And the reason for that is because you're looking at the lens in the slit lamp with the eye open. And the patient, the treatment is actually happening when their eye is closed, right? Because they're asleep. And so I found it interesting. There was John Mountford, very experienced in orthokeratology, found in a study in 2004 that when they compared novice versus experienced fitters, there was really no difference in their ability to accurately assess a lens fit with fluorescein unless it was completely terrible. And so you want to make sure that it fits the parameters of ideal, but it may not affect your outcome if you're seeing a problem in the open eye state or on eye state. So fluorescein patterns aren't going to tell you as much as topography maps. And so when you're working with consultants to try to make changes for these patients, you'll find that sometimes they don't even ask you what the fluorescein pattern looks like. We did talk about earlier looking for that turricity, that kind of leaking of fluorescein. That can be helpful, but they really want topography maps and other data to help determine if the treatment is progressing as expected. And so again, the lens fit is determined by the closed eye state, and we're able to gauge how that works through doing corneal topography. If we look at that in combination with our refractive data, our visual acuity, and our over-refraction, that can be quite informative as to how we're doing in terms of treatment. So I'll just show you some photos of a decentration. And I say this also knowing photography just gives you one kind of point in time. And so if you're taking a picture of a lens fit, depending on where you take it, on the left here, this lens could look fairly well centered. Obviously, there's some leaking of fluorescein in the vertical meridian. But if you wait a second and that lens drops, that lens is decentered. And so from a consultant's perspective, or when you're trying to make a change, the question would really be, what happens on the topography? Is the topography showing you that the lens is well centered, that's consistent with the fluorescein pattern on the left? Or is the lens decentering when the eye is closed, which is more consistent with the pattern on the right? Your topography will really be the king there in terms of telling you what to do. Here's just another example of that same kind of thing, where the patient's on the left, their eyelid is pulling the lens up and out, decentered. And then as they blink it, they kick the lens down and out. And so neither of those are lovely and centered, but this patient actually was doing fine in terms of their topography. So with that, I'll wrap up. And I really want to say a special thanks to Abby Cantilina, who is the Senior Director of Consultation and Customer Relations at Euclid Systems. I just kind of picked her brain to kind of get information on what she thought were some common mistakes that practitioners made, and helped to try to kind of combine that with my experience. So I'm really grateful for her kind of brain input that went into this talk. And so I want to thank OOLS for the invitation to present to you today. It's been fun. I'll certainly take any questions. And if you want to reach out to me via email or via LinkedIn, I'm happy to connect with you.
Great. Okay. Thank you so much, ma'am, for that wonderful presentation. Quite refreshing. And I think a lot of things which are really important, I would say, as a beginner, and seeing so many students here, we tend to, do these quite often. and the most important one, I think, is for me basically is to make changes very fast. Don't make changes very fast. Wait until things settle. So thank you so much for sharing those with us, so that we try to get out of that and probably be better clinicians, as I was saying in the earlier session. Thank you very much. There was one thing which I was curious about in terms of the fitting assessment. So you did mention that you have to look at everything together. Don't just base on fitting assessment. Look at the topography, look at the outcome as well. My doubt was, or probably you want to share your expertise on the fluorescein assessment when it comes to instilling the fluorescein. Do you prefer to instill it after the lens, or do you dip the fluorescein in the on the bowl and then put the lens on? What's the kind of thing which your experience or expertise say?
Yeah, that's a great question. I love it. We didn't talk about this beforehand, but no, that's a fabulous question. Yeah. So actually what I like to do is I'll put the lens on and then take the fluorescein strip and wet it just a little bit. And then I actually touch the fluorescein strip to the front of the lens, just lightly, like on the side. And that tiny bit of fluorescein is really all you need. It can be very challenging if you flood the eye with fluorescein. It affects not only the lens fit, because there's so much tears behind that the lens starts to go everywhere, but also it can affect your assessment of the pattern. So you don't want too much of that front surface fluorescein. It can make things look like they are not. And so one of the other tricks that Dr. Jerkis, in all her wisdom, taught me when I was younger was have your patient blow their nose. And so if you instill fluorescein and you feel like it's too much, their lacrimal lake is filled with fluorescein, hand them a tissue, have them blow their nose, and it will pull some of those tears down into their nose, and that will pull it out of their eye, and that can help you view the fluorescein pattern as well. But I think the way you mentioned earlier, putting a little fluorescein in the bowl before you put the lens on, that can also be a good strategy.
Right. Because I try to do both. And I felt that when you put it in the bowl, it's much of a quicker fitting assessment, which you can see. And, we don't want to waste time in terms of letting the lens on the eye for very long, so that the second lens, hopefully we don't have to fit a second lens. The first lens is the best in most cases, if you do your baseline data correctly, as you were saying. But just that, I just wanted to get your opinion. So yeah, the blowing nose thing is really something very useful as well, right? To just get that tears out and make sure that you're assessing the actual fit rather than getting the tear influenced.
Mm-hmm.
Right. Okay. I'm just looking at the first question which came in. It's about the pupil size in terms of, the experience of halos and glare. So has there been any patients where you had this trouble, and what was their pupil size? Or in other words, what's the largest pupil size you probably have fitted with Orthocare without problems?
Yeah. This is all about managing expectations. I have patients that have 8mm pupils in dim illumination, and they're still fine in Ortho-K. They just know that if they go into that dark room or, are at dusk or in a restaurant, or for my optometry students, if they're going to do retinoscopy, that they may have that glare and halo. So it's not that they can't be successful, they can. But when you get to those larger pupil sizes of more, I would say more than 7, even if you get 8, 9mm pupils in dim illumination, that can be really challenging.
Right. So, yeah, I think you did mention about measurement of pupil size and make sure that you did measure them under different illumination as well to be just sure that you don't have that experience with patients. Right. One question which came in to me here on the personal chat, I'm just going to read that out to you. If given a choice, which topographer do you suggest as a beginner student? I'm going to open my practice. So out there are too many topographers, and you did talk about topography in the first mistake. But any suggestions you think which probably we should look for in a topographer if we are doing orthokeratology?
One thing to think about might be if you have a certain lab that you're going to work with and you have a certain design that you're going to lean on, might be asking the laboratory if they have a suggestion. And I say that because they may be more familiar with working with the files from a certain topographer, or it may give them information that they can use. So we have a Medmont. I think that's a fairly popular model. Not to say that you need that one to do orthokeratology, but it has some elements in it where you can dig into the file and get those things like those sagittal height and things like that. You can get that out of other topographers, certainly. As long as it has placido disc imaging, which our topographers mostly do, you can be successful. So it doesn't have to be anything specific. One other thing to consider would be the cone size. And so when you put your eye up to a topographer, there are small cone designs, which you put your eye up to like a little, instrument that touches the eye. And then there are large cone designs where you just kind of look into it. And so if you have patients that are going to have a prominent brow or deep set eyes, it can be hard to even image those patients with a small cone design. And so you may find that if that's your patient population, that you want a large cone design. Because we image 150 students every year. There's always one that we can never get because they just can't get their eye into our small cone. And so we can take them to the large cone design that we have.
Right. Thank you. Thank you so much for that suggestion. And the other question which came up again was, you did talk a little bit about this in the slides as well, but just to throw light more, how would you approach a patient where he complains that the lens is stuck on the eye and is unable to open the eyes? Any suggestions or tips you would give to such patients?
Yeah, that's never a great scenario when you're getting the call on your office line at 7 a.m. and the patient says that's happened. So a couple things to think about. One would be to flood the eye with artificial tears, preferably preservative-free, and let that patient kind of sit with the eye closed still. And you can kind of deposit those in by the nose if they're having a hard time opening the eye to get the tears in. And then I talked about kind of closing the eye and gently nudging that lens with the eye closed to make sure that it's mobile before getting it out. This might also be a scenario where you have to meet the patient at the office and help them get the lens out. And again, whether that's because the lens was just dry, maybe it didn't go on with tears, or maybe it's a fit problem. You can have lens adhesion or adherence as a result of a fit that's too tight. So you'd have to kind of determine that from a follow-up visit, but really flooding the eye with tears, letting it sit. And then that's also a scenario where a suction cup remover might be helpful. You can have someone else kind of come in, pry the eye open, and remove the lens, or that's something you can do in your office for the patient. But you also want to rule out an infection in that case as well. If it's kind of painful and they can't open their eye, hopefully they haven't had some sort of corneal abrasion or ulceration.
Right. Yeah. So look at everything together. It's more of, making sure other things are also well, right?
Yeah.
Great. Okay. The other question is, do you really recommend in terms of, when you want to replace lenses every year for your patients, do you recommend them to lay off the lenses to collect the baseline data again, or you kind of go with the flow, or any cases where you recommend to lay off? Any things on that?
Yeah, great question. So if your patient is doing well, you do not have to de-adapt them every year and start over. And even if they're having an issue, usually those issues are not to the point where you need to have them, discontinue lens wear and gather new data. The cases where you might have to do that are if they have overworn their lenses and it's been a few years and the lens is causing a physiological problem. So I had a patient recently who had given himself a corneal abrasion, had neovascularization, and basically an inflammatory response to a lens that was over 3 years old. And so we had him discontinue lens wear, stop that lens, for 3 weeks, and then treated his cornea, had him back, redid baseline data, and started over. You don't have to do that very often.
Right.
The only other time I could think of where you might consider doing that is if you have a parent who is very concerned about myopia progression and really wants to know if the prescription has changed. And I think we can educate them on there are other ways that we can assess that. We can look at the axial length, we can look at the over refraction. And if the lens treatment needs to be changed, we don't necessarily have to de-adapt them just to see what their refraction is, which might be what the parent thinks needs to happen. So there's very few scenarios, I think, where that's necessary. One other thing that comes to mind might be if you're changing lens designs, like if you're not getting the appropriate myopia management or even appropriate treatment that you're expecting with one design, before you go jump to another design, you may find that the lab will request that you de-adapt the patient and start over. That's not always the case, but it might be.
Might be. Right. Great. And I'm just going to read out one last question in terms of changing the size of the treatment zone. So do you often just manipulate the treatment zone, and in which patients, or how could you do that? Is it just by changing the fit, or you do something else in terms of changing the size of the treatment zone?
Yeah, great question. I would say this is something that, again, is like research kind of is ongoing about this. Not all designs have the ability to do that in this moment. But I think it's something that's coming. And the reason that becomes important is because there may be some mechanism for us to adjust the size of the treatment zone to improve the myopia management capabilities of these lenses. And some of that goes along with the patient's pupil size and getting that reverse curve kind of inside the pupil to give us the best myopia management, right? We want that peripheral hyperopic defocus to be within the pupillary zone so that the patient has that advantage to wearing Ortho-K. And so if we can manipulate the size of the treatment zone, we can maybe better improve the myopia progression or reduce the progression. And so it's not something I think about right now on a daily basis when I'm fitting these. I kind of just let the lab default to their preferred or recommended treatment zone based on the overall diameter. But if there is a case where you're not getting enough treatment, you may want to make it larger. Or if you aren't getting enough myopia management, you may change it based on the pupil size. So I think that's something that's coming, is more customizable treatment zone diameters like that.
Right. Great. And just taking up one question, what's your personal favorite? Is it the diagnostic fitting is what you prefer, or you are more on a designing lens person? You design your lenses and then order the lens, or you prefer a diagnostic fitting? What your suggestions?
I like them both for different reasons. Again, like kind of depends on the patient. If they come in and they're super gung-ho and they want a lens today and they want to start, that is a patient that I want to fit from my diagnostic set. But I would say the majority of our patients, we're doing a myopia management consult, deciding that Ortho-K is the way we want to go. And then I would say the majority of my fits are empirically designed. It gives you a little more customization with the first lens for that particular patient. But I also have the advantage of having both available to me, which I know not everyone does. And so whichever lens you have available to you is a good lens. But again, there's different scenarios where I may choose one over the other. I don't think there's a right or a wrong answer there.
Right. Great. So I think with that, thank you so much, Dr. Sicks, for that wonderful talk and sharing your experience and answering the questions. Really informative, and I think the attendees would have definitely learned a lot of numerous tips and tricks so that they would be applying that into the practice and minimize, if not make it zero, but probably minimize all those mistakes and get more practice patients and help their patients also. Thank you so much for sharing your thoughts with us today.
You're welcome. It was super fun to be here.
Just to be reminded that we also have a session planned next weekend. It's slightly a continuation of today. It's more about orthokeratology in myopia management, and we have someone talking about the use of orthokeratology, specifically children and in myopia management. I wish to see you next week. Until then, take care, be safe, and bye-bye. Thank you, ma'am. Thanks.
Bye.
Bye-bye. Bye-bye.